I know for many years that the criteria for neuromyelitis optica, which were established by the Mayo Clinic team, Dean Wingerchuk and many others there, and also internationally, that they are very, very helpful in defining patients who have a form of brain disease and spinal cord disease in particular, which requires urgent immunotherapies. And urgent because they have severe relapses often, and because if you don't treatment, the damage from that relapse may be permanent. It doesn't easily resolve. So this has been very important to identify these patients, and particularly when they found a very specific antibody in these patients called aquaporin 4 antibody. And the question really is it better to have the clinical diagnosis or the antibody diagnosis? Now, initially, the antibodies were found only in patients who had the clinical spectrum. And some of the patients with the clinical spectrum were negative for the antibody. So clearly the clinical spectrum of NMO was better because all those patients, or most of them, responded to the immunotherapy, even though not all of them had aquaporin 4 antibodies. But they began to realize that it wasn't quite that simple. And more recently, the revised NMO criteria in 2015 allowed for patients who only had the aquaporin 4 antibody, but not the full criteria of NMO. So that meant that you could include all the aquaporin 4 antibody patients and all the clinically established patients in one group and treat them fine, except that there's another antibody called MOG, and many people now recognize that. And MOG antibodies are found not only in that spectrum, but also outside the spectrum in patients who have a clinical disease which is equally treatable, in fact, more treatable, more easily treatable, but isn't confined within the spectrum of NMO and aquaporin 4 antibodies. So I think, and this was really my take-home message at the end, that what one needs is a combination of both the clinical definitions, because they're helpful in establishing which patients have aquaporin 4 antibodies and which patients to test for other antibodies, perhaps newly defined antibodies that we don't know yet. But aquaporin 4 antibodies alone isn't enough. You must test for MOG antibodies in any patients who have a wide spectrum of symptoms, which are largely similar, but not necessarily confined to the NMOSD criteria that exist nowadays. And that's particularly important in children, where the MOG antibodies and the criteria are quite often not fulfilled and are equally important to treat. So basically, the antibodies are extending the criteria of patients who have to be treated. Lastly, it's important to understand that there are at least two main antibodies now that we are completely separate, and they actually require somewhat different treatments. So we have to define the patients first by their antibody so that their treatments can be tailored to the type of antibody they've got, and not just give everybody the same treatments that they used to give or that we gave for and still give for aquaporin 4 antibody disease, which on the whole is more serious than the MOG antibody disease, which responds more easily to treatment. So I felt very strongly that you need really both, to be honest. I suppose I hadn't really made this clear. There are still patients with NMOSD criteria clinically who we can't find any antibody in. And for them, you need the criteria to define those patients.